and Dr. Nawal AL-HAMAD from Kuwait will tell us about the regional strategy, the WHO regional strategy in nutrition. Dr. Nawal.
Assalamu alaikum. Good morning. It's my pleasure to be here in Marrakech, beautiful Marrakech, and I'd like to thank the Moroccan Society for Nutrition for inviting me and to be participating in this beautiful and very interesting meeting. My presentation, as mentioned, is on the Regional Strategy on Nutrition 2010. 2019, and the Plan of Action. And I would just like to add that this has been prepared by a group of nutritionists and scientists at the EMRO office, the Eastern Mediterranean Regional Office of the WHO, and was published last year, 2010, and it was endorsed by the Ministers of Health of the countries of the region in their annual meeting at the headquarters in last October 2010. So Ministers of Health have this document. So as an introduction, the development and growth of a nation depends, of course, on adopting the appropriate health, nutrition, and population policies. Nutrition ensures security because adequate food is vital in keeping people alive, and of course is a basic need and human right. Undernutrition in this region coexists with high rates of overweight, obesity, and other non-communicable diseases. The World Health Assembly Resolution 62.14 on reducing health inequities through action on the social determinants of health called on the member states in the region to tackle these health issues. The implementation of this resolution is key to addressing the root causes of malnutrition, including poverty and inequality, and to improving livelihoods, especially in the most vulnerable groups. This paper I'm presenting this morning is an analysis of the regional nutrition situation, its causes and consequences. It stresses the importance of a regional nutrition strategy because it defines the priority areas of action, which include monitoring, advocacy, strengthening the implementation of nutrition programs, promoting community participation, and finally mobilizing resources. To start as a background, the region faces many challenges. Following the 1992 recommendations of the International Conference on Nutrition, which was held in Rome, and the World Declaration and Plan of Action for Nutrition, many countries in the region developed national nutrition plans of action. However, most have not been fully implemented and/or do not have a clear strategic path for implementation. To analyze the situation further, the burden of disease associated with inadequate nutrition continues to grow in this region. Over the past 30 years, the region has witnessed significant social, economic, demographic, and political change. Undernutrition still exists, and with it is overweight, obesity, and diet-related non-communicable diseases, which are increasing. It's really an alarming situation. It faces other challenges: in-country inequalities, conflicts, and political unrest, limited natural resources, water and agricultural land, recurrent drought conditions, high population growth rates, and AIDS in some countries. But the key nutrition challenges that we are facing in the region are malnutrition, micronutrient deficiencies, obesity and non-communicable disease, and finally foodborne diseases. We'll start with malnutrition, which is a major health problem. It is the single biggest contributor to child mortality. It represents 15% of the global burden of newborn and child mortality. In the countries of the region, 50% of deaths in children under the age of 5 is attributable to mild, moderate malnutrition. The consequences of early childhood malnutrition are irreversible and, as we heard this morning, intergenerational. The impact on mental and cognitive development is unquestionable, thus inflicting adverse effects on adult health. The overall proportion of underweight in children under the age of 5 has increased from 14% in 1990 to 17% in 2004. And subsequent to the global food and economic crisis, which started in early 2008, the nutrition situation of infants and children under the age of 5 has further deteriorated in countries in complex emergency situations. This is a table that I'm presenting, and the authors, one of the authors are here, and it's compiled data, but it goes a little bit back, 1992, 1995, from UNICEF and FAO, and just gives an idea about underweight, stunting, and wasting. Some countries really have very high figures, such as Somalia, Mauritania, Sudan, and Djibouti. Others are a little bit better, but there are, the figures are not very accurate. I can tell for Kuwait, the figures are not right, but, at least this is one thing that we need: continuous data monitoring and obtaining data to ensure that we're doing the right thing, especially with so many intervention programs are at hand at the moment, to just follow up, to monitor and evaluate continuously. This is one idea, that stunting, according with WHO standards for children under the age of 5, and same thing for underweight. And a problem in Kuwait and in the Gulf, it's more towards overweight and obesity, actually. For women, malnutrition, again, during the reproductive age, malnutrition increases the maternal mortality ratio and the risk of low birth weight for their children. The mean maternal mortality ratio was estimated to be 210 per 100,000 live births in 2005, representing only a 20% reduction from the levels in 1990. Unless policies and priorities are changed, the scale of the problem will prevent many countries from achieving the targets of the Millennium Developmental Goals. This is an important area: micronutrient deficiencies. Several micronutrient deficiencies are still being reported from many countries of the region, and although we don't have continuous data on this issue, but still, iron, iodine, zinc, calcium, and folic acid, as well as vitamins A and D, particularly among vulnerable groups. Anemia, for start, and iron deficiency anemia. It is estimated that more than 1/3 of the population in the region is anemic, and according to the WHO criteria, a total of 149 million to be iron deficient or anemic, and 83 million of them are anemic women. Again, from the same authors, the table is showing anemia, vitamin A, and iodine. But let's concentrate on the anemia at the moment for non-pregnant women, and anemia in pregnant women, and for those in children up to 5 years of age, showing really high levels, especially in the countries that I've just mentioned, but also in other countries. The most burden is on women of childbearing age, and it shoots up for pregnant women, where the needs are higher, but the intake is much lower. But again, the data is not very accurate. I'm just showing, Kuwait, 1/3 of the pregnant women and more than a quarter of the adolescents and young children are anemic, iron deficient. So data on anemia rates in preschoolers, pregnant women, and women of childbearing age from 1995 to 2001 show no improvement in the overall situation. In Bahrain, for instance, the prevalence reached 48.3% among children under 5 years of age, and 41.6% among children between 5 and 14 years. In women of childbearing age, the prevalence of anemia was also reported to be approximately 40% in both Oman and Bahrain. And I'm quoting these countries because the data is coming, it's available. With regard to vitamin A deficiency, which is considered a public health problem in many countries of the region, of course, the groups affected are preschoolers, again, school-age children, and women of reproductive age. It is highly prevalent, with 0.8 million preschool-age children estimated to have night blindness, and 30.2 million preschool-age children with serum retinol levels below 0.7 micromoles per liter. Again, concentrating this time on vitamin A, showing high levels in some countries compared to others, with the complication of exophthalmia. Vitamin D deficiency is a big problem in the region. Again, very little data on vitamin D. However, there is speculation on widespread hypovitaminosis. There is some data on intakes, for example, in Lebanon, where it's shown that vitamin D intake is below the recommended daily intake among the 30 to 50 years of age, and this is in 2005. And the same for Kuwait, where women are more affected than men in all these both age groups. In Qatar, vitamin D deficiency is almost 70% among children less than 16 years of age. For iodine, of course, Dr. Izzeddin is with us today, and I'm sure he'll be talking more explicitly about this issue. Iodine is a significant public health problem in 18 countries. 1/3 of the population is estimated to be at risk of developing iodine deficiency disorders. We know that it's detrimental, it has detrimental consequences for the fetal brain and for cognitive and functional development in early childhood. And there are so many intervention programs in the region, and iodization of salt is by law in all countries of the Gulf region. The prevalence of iodine deficiency disorder is considered to be mild in some countries, such as Jordan, Lebanon, Libya, Oman, Syria, UAE, and Yemen, whereas it's found to be moderate in Egypt, Morocco, Saudi Arabia, and Sudan. In Kuwait, although we don't have data up to 2004, but in 2008, a group that was a subsample of the survey that was done in Kuwait, we assessed iodine deficiency, and there was none found in women of childbearing age. This is from Dr. Izzeddin's publications, data on the iodine situation in the different age groups, showing comparable levels, but it is a problem to be addressed, and the intervention program, which is for iodization of salt, is present in many countries. The other big problem is obesity and non-communicable diseases. In 2005, it was estimated that non-communicable diseases account for 52% of all deaths and 47% of the disease burden, and the latter is expected to rise to 60% in 2020. And among the populations aged 20 years and older, it is reported that the prevalence of diabetes is 11%, hypertension 26%, dyslipidemia is 50%, overweight and obesity 65%, and finally physical inactivity is 77%. This has an impact economically on the direct, indirect costs, and intangible costs.